It's an election year, and here in Ohio, ads for U.S. Senate candidates center around three major themes: immigration, the economy, and fentanyl. According to a study about opioid, heroin, and fentanyl markets, the widespread use of these substances came in waves. The first wave was driven by prescription opioids, the second by heroin, and the third by illicit non-pharmaceutical fentanyl. Changes in pain management standards coupled with increased marketing by pharmaceutical companies nearly doubled the number of opioids prescribed between 2000 and 2010. In that same period, prescription opioid-related overdose deaths in the United States also rose, compelling the federal government to regulate opioid distribution and prescriptions more closely. Measures such as closing pill mills and implementing prescription drug monitoring programs reduced the street market availability and increased the street pricing for non-medical prescription opioids. This prompted many people who had become addicted to their prescription pain meds to turn to heroin, and the overdose deaths rose at alarming rates. Then, in 2013, illicit fentanyl started showing up in the heroin supply, as well as the supply of other substances such as cocaine and methamphetamine. Based on a report by the National Institute of Drug Abuse, the number of people in the U.S. who died in 2022 from drug-involved overdoses was over 100,000, the majority of which were attributed to fentanyl. Compared to attitudes in the 80s and 90s, even the early 2000s, addiction is largely considered a disease today, and widespread abuse of opioids, heroin, and fentanyl has warranted the declaration of public health crises in communities across the country and influenced the way criminal justice systems process people who suffer from addiction and commit a crime. Specialized dockets and diversion programs are taking the place of more punitive sentencing and incarceration. The opioid crisis has also impacted law enforcement and even sparked a debate about the role police should play to mitigate the harms these drugs continue to have on people and communities. From the Drug Enforcement and Policy Center at The Ohio State University, this is Drugs on the Docket. Each episode will tell the story of how U.S. court decisions impact drug law and policy and continue to shape the war on drugs. I'm your host, Hannah Miller. Today, we discuss the roles of stigma and law enforcement in the overdose crisis. If you like what you hear in today's episode, visit go.osu.edu/drugsonthedocket to follow the series. I'm flying solo today as the host, but am joined by the fabulous Tasha Perdue, who is a Drug Enforcement and Policy Center affiliated faculty member and an assistant professor at the John Glenn College of Public Affairs here at The Ohio State University. She's worked in various capacities for public health as it relates to mental health, addiction, and harm reduction. Her current research focuses on the impact criminal justice responses to drug crises have on risk and drug use. Welcome, Tasha.
Thanks for having me.
I'm excited to have you join me for this episode. And even though you're a guest, I would love for you to do the honor of introducing the second guest.
Yeah, sure thing. I'd love to. So here to chat with us is Sydney Silverstein. Sydney is an assistant professor at the Center for Interventions, Treatment, and Addictions Research at Wright State University. Her scholarship explores the war on drugs and the diverse social worlds that come together around the production, circulation, use, and policing of illicit drugs. She has conducted research in South and North America on topics related to the drug cultivation, overdose prevention, and addiction treatment and recovery, as well as the role of the criminal justice system in managing substance use disorders.
Hi, Sydney.
Hi. Thanks for having me on the podcast, and thanks for the sweet introduction, Tasha.
So many of our guests and co-hosts on this podcast have been law professors or legal professionals, but I'm excited about today's episode. I think it's going to be extra fun because neither of you are lawyers and I'm not a lawyer. So Tasha, your PhD is in social work, and Sydney, your PhD is in anthropology. The two of you together are currently collaborating on research related to overdose responses and exploring the attitudes police have about these types of calls. Before we dive in, I'd like to know, how do your respective fields inform your research? Because when we talk about the war on drugs, or we say war on drugs, even though there's been a lot of effort to see and treat drug use and addiction as a matter of public health, many still think about the criminal element of drug use, like theft, guns, trafficking, violence. And therefore, the first thing that may come to mind is public safety.
When you think of social work, you may think of more of the individual interpersonal work. And I did start as a case manager for adults with severe and persistent mental illness. And while working with the population, I really started to see a lot of the systemic sort of barriers that could impact their access to care. And that also could create some disparities in care. And in my work, I have that understanding of the complex factors on the individual, family, community, as well as the larger, more macro policy side that can really impact individuals' trajectories. And my research really seeks to address how do we approach this from a more systems level, and how can we work to reduce the risk through addressing this on a broader level.
Where Tasha kind of looks at macro systems level thinking, I think about how things like policy and these kind of macro and meso level forces play out like on the level of the individual and the individual body as someone moves through life, as someone moves through their day over time. I've had the privilege to be able to do longitudinal ethnographic research in Dayton now for over 5 years. So one thing that I really enjoy doing is sort of understanding how shifts in policy, how shifts in procedures, how kind of the political climate will affect how people who use drugs or sort of anyone related to this war on drugs ecosystem moves through their life, makes a life for themselves, develops workarounds, manages risk. I kind of take the more micro, in-depth, smaller sample size, but in greater ethnographic depth and over time. The other thing I would say is that I'm trained as a cultural anthropologist. What that training has really taught me to do is kind of learn how to sit with difference and listen to it and kind of be curious about how people who are really different from me come to make a life for themselves and come to understand social factors and deal with different day-to-day realities. And so this kind of training has helped me, early on in this research in Dayton, deal with people who had, for instance, really extensive criminal justice background. Maybe they had some kind of, Aryan Brotherhood prison gang tattoo or something, which initially was unsettling to me, but kind of to learn to sit across from that person in an interview and sort of listen to their story and not immediately judge and understand what was going on. And this research in particular, I had this decent amount of experience working with people who use drugs. But then when Tasha and I began collaborating, it was also how do I expand that ability to sit with difference and be curious to law enforcement. So I had really no experience working with law enforcement other than getting pulled over in my car. So kind of learning to be open-minded and curious about them, their reasoning, their experience really helped as well. I will say, although my interest is on this more granular level, I also like to think about how things like drug trafficking networks and the war on drugs kind of connects, especially the Western Hemisphere. It's really sort of a global issue.
As I alluded to earlier, the two of you have teamed up to research overdose responses and law enforcement attitudes about overdose calls. And this research is specific to Ohio, or at least Ohio communities. But in terms of overdose deaths, how does Ohio compare to other states?
We have historically been generally in the top 5 states for overdose mortality rates. That's a rate per 100,000 population. We did see a slight decline, but we started to see that sort of tick up again. And especially with the pandemic, we saw our rates surpass 5,000 for the first time. And the rates have fluctuated due to new drug market trends, the emergence of fentanyl. And there was that reduction likely related to a lot of the community outreach that we saw, the expansion of naloxone. But the drug market continues to be very volatile. It's very hard to know, potency levels. As far as trends in Ohio and on the national level as well, we did see a big spike in 2021. For the first time here in the U.S., we surpassed over 100,000 deaths due to drug overdose. There have also been shifts in populations affected. For instance, here in Ohio, the overdose mortality rates among Black residents surpassed white residents.
So there's an upward trajectory in the number of overdose deaths, and the overdose mortality rates are higher for Black residents compared to white residents. So what's driving that trend in Ohio? Is the opioid crisis sufficient explanation? Have more Black residents become addicted to pain meds and have turned to heroin? Or is it that there are traces of fentanyl in everything now?
On the state level, the state crime lab, in the testing that they do, there has been fentanyl in substances other than heroin. I don't know the current numbers, but I know there was an increasing presence of fentanyl in drugs other than heroin.
It's really important to sort of think about trends on a local level. I have the privilege of working with a really amazing behavioral health epidemiologist at Public Health Dayton Montgomery County, Susan Hertzfeld. She's incredible. And she's pulled together some really interesting reports in the past few years that have showed actually increase of overdose deaths for people who use stimulants with no presence of fentanyl or opioids detected. And this is also kind of coming along with the increase in rates of overdose death among African American males. What's happening here is super interesting because there's a lot of talk about this association between African American men and women who use cocaine, getting drugs that are contaminated with fentanyl, which could very much be the case, and I think does happen. But the other thing is a stimulant-related overdose from methamphetamine, cocaine, crack cocaine, any combination of stimulants is not sort of the same as getting a fentanyl contamination, right? It's sort of further taxing a system that's been taxed for a long time with, maybe high blood pressure, heart disease, hypertension, diabetes, and sort of using stimulants to a point where your system kind of just can't take it anymore and it goes into overload and someone does pass away. That's very different from an overdose where you see fentanyl in the drugs and someone can be Narcaned and revived. But what we've seen in Montgomery County, and again, I have no idea if this happens in Franklin or elsewhere in Ohio, but in the past 2 years, we've seen an increase in overdose death among folks who use stimulants with no presence of opioids. And, even before the kind of current incarnation of the overdose epidemic, drug overdoses were occurring from stimulants. They just looked really different. And so there is, I think, a certain panic around fentanyl's in all the drugs these days. It's in the meth, it's in the coke, and it is sometimes, I don't want to deny that it is. It certainly happens. But I think if we center the fentanyl, we could be missing out on some of the larger causes of unnecessary morbidity among people who use drugs. But again, drug markets are so highly localized. And so fentanyl contamination of stimulants could be a huge issue in one area, but there's other kind of complicated things that we're taking into consideration in doing our outreach and harm reduction efforts.
What is harm reduction and what can it look like in the context of public safety versus the criminal legal system versus the healthcare system, or even for an individual?
There's a variety of harm reduction outreach. So we can think on the more sort of individual level, providing individuals with things like Narcan, the fentanyl test strips. Some areas are distributing xylazine test strips as well, clean syringes. There's safer smoking kits or safer snorting kits. We have seen some individuals make changes in how they use, just based on some of the drug market factors. So we have seen some individuals shift to maybe more smoking or snorting. But then we can also think on the more structural level. So how can we work to better support on the community level? That could be accomplished through things like drug testing. So providing areas for individuals to come in and to be able to test their drugs, to see exactly what's in it. Providing individuals overdose prevention sites where individuals can come in and be able to use in an area with someone sort of there to respond if an overdose does happen. We also have seen hotlines emerge. These are phone numbers that individuals can call. And so they don't use alone. Being creative and innovative in our harm reduction approaches and outreach and being able to shift. Again, as we see the trends changing, I think being able to shift and make sure that the harm reduction is following those trends as well.
Sometimes this whole notion of harm reduction gets kind of almost like fetishized in these things like a needle exchange or Narcan distribution. But harm reduction at its core is a philosophy that's really not about necessarily drug use, but it's about radical empathy, understanding that people are on their own path and to try to refrain from judgment, but just help them have the ability to make choices in a positive direction, whatever that may look like. And so oftentimes that gets manifested in technologies like clean syringes, Narcan, safer use supplies, but really it's just sort of supporting someone in their journey and not trying to push your values on how you think they should or shouldn't live their life. And so it's an interesting debate in treatment circles because there are some substance use treatment facilities that kind of prefer the stick over the carrot approach. So if they see someone who continues to use while in substance use disorder treatment, they're kind of considered non-compliant and are faced with consequences, maybe have a medication cut off or kicked out of a treatment program, to sort of use a disciplinary approach to try to help people stop using, right? But then the harm reduction approach says, we're not going to punish you for continuing use. What we really, our priority is keeping you engaged in care, getting support. And so we're not going to necessarily look at a urine drug screen as an example of progress. If you're kind of able to articulate positive change, we'll take your word for it. But there's a huge debate among treatment centers and even within a single treatment center. It can be a huge source of tension, especially, in the 12-step recovery community that tends to sort of favor abstinence-based approaches. They see this kind of harm reduction permitting continued drug use to be really harmful. Other people see it as life-saving.
Sydney, you said earlier that centering the drug isn't the most effective way to deal with a drug epidemic. Can you elaborate a little bit on that?
So if we refer to this kind of current crisis or epidemic as something that was caused by opioids, kind of covers up some of the collective pain, disillusionment, frustration, decay of social fabric, all these other things that are really at the root issue of addiction and kind of mental health crises. I think it's important also to not assume that the drug itself is a crisis or an epidemic or a problem. Like, without denying the very real damage that alcohol can do to families or individuals or communities, I think we can also recognize that there's many of us who may be able to use alcohol in a responsible way or even a therapeutic way. And the same goes for other drugs too. The actual crisis that I think we can all agree that we're dealing with is overdose. So we are experiencing epidemic level rates of both non-fatal overdose and overdose death. And I think that this is an issue that people across different social and political spectrums, be they people who use drugs, harm reduction advocates and activists, researchers, public health officials, law enforcement, policymakers, we can all kind of agree we don't want people to die from overdose. So if we think about the crisis and the problem that we're looking to understand better and create solutions towards, the unnecessary overdose death, I think it can kind of take away some of the misleading things of saying the crisis is in the opioids, or, it's the fault of this drug, or using drugs as in of itself is, a problem. What's the problem is dying from an overdose when you didn't have to.
Could we talk a little bit more about the police response and whether or not they employ any harm reduction strategies and how they respond to the overdose crisis?
I rarely talk to a law enforcement officer who says, I'm a proud harm reductionist, right? That tends to be more of like the Sydney and Tasha social science, social worker, outreach worker, public health person. That being said, law enforcement applies a lot of harm reductionist strategies, whether they like to come out and sort of refer to themselves as a harm reductionist agency. I don't know about that. But if you actually look at their practices, some are definitely practicing harm reduction, practicing radical empathy, taking individuals to treatment. Tasha, do you want to talk a little bit about the GSLs?
GSL meaning Good Samaritan laws.
Yes. Ohio, we implemented ours here in 2016. And these laws provide immunity for individuals, both who are calling for as well as those who are receiving overdose assistance. And they're for low levels of drug possession at the scene. These are to facilitate more of a public health response to overdose response. The majority of states have adopted some form of Good Samaritan law. They vary in what they look like. Here in Ohio, we had some changes to ours last April that expanded protections to include individuals on probation or parole. They included protections for paraphernalia as well. That was another big provision that was added. And then there is a treatment component associated with it. And I'm not sure how often that is enforced, but individuals are supposed to seek treatment within 30 days. And these are really, again, to provide this more public health approach while also encouraging people to reduce overdose mortality, essentially. So we have more individuals, who may be comfortable calling. And then if we can have more individuals calling, then we can save more lives. I think what we're trying to understand in our study is, what is this application of the Good Samaritan law look like here in Ohio? And how do individuals feel about the law? So how educated are people who use drugs on the Good Samaritan law? We're finding preliminary look, there is limited knowledge. So I think the other key is how do we educate individuals about the law? How do we, let individuals know what is protected and what isn't protected? Because individuals with warrants, there's still no protection there. So it's up to the individual officer if they decide to run names when they're at the scene. Some officers, do decide to run names, other officers don't. So I think that no protection for warrants is a big area where there's a gap. So that could still, make individuals hesitate to call or those protections just don't apply.
Meaning if an individual has an active warrant or a bench warrant and they witness an overdose, they may not call because that warrant could be called up and they could be arrested.
Yeah, they can have that fear. And again, that's up to the officer as well, what that looks like, that enforcement looks like. So some of them, they'll talk about calling and just getting a date. Obviously, if it's a more severe warrant, then the options might be a little more limited.
And what law enforcement would say is with body cams, they're being monitored to make sure they're checking for a warrant. And if they run a felony warrant, they don't have the option of using discretion. This is what they tell me. I don't know how it plays out. I'm not a law enforcement officer, but I want to loop back to the paraphernalia thing and sort of talk, Hannah, to your original question about law enforcement and harm reduction. So I think one thing that really surprised me during this research, but pleasantly surprised me, was that law enforcement actually can be an ally for harm reduction, it can really benefit them. So if we look at something like a paraphernalia charge, right? Like one of the huge changes that law enforcement officers in Dayton, at least, would sort of talk to me about in this era of increasing opioid use is this fear of needle stick injuries. If people fear a paraphernalia charge, they're not going to admit to an officer that they have a syringe on their person because they're fearing arrest. So if an officer pats them down and they have a hidden syringe, right, the officer risks a needle stick injury, which is, I think, universally scary. There's tremendous fear about infectious diseases, HIV, Hep C, fentanyl contamination. If you can eliminate the threat of a paraphernalia charge, it opens up a point of conversation to where if an officer says, do you have a needle on you? And if someone's no longer afraid of being arrested, they could say, yes, I have a needle on me. Let me take it out before you pat me down. And so in some ways, like these sort of measures of kind of, harm reduction, reducing paraphernalia charges can actually be a point where law enforcement would be happy to go along with it because ultimately it benefits them. I was also very interested to learn, like in Dayton, Major Brian Johns, who I think has been a great ally of harm reduction, was instrumental in opening Dayton's first syringe exchange program, which was run through Dayton Public Health. Because it was something that was sort of sanctioned by local law enforcement, I never hear kind of accounts of officers sort of patrolling or people being picked up outside of the syringe exchange for paraphernalia charges. The police always recognized that the syringe exchange was operating through public health and let it be, and there could be a more open conversation around drug paraphernalia. It reduces harm. People are like less afraid to be, accessing clean drug paraphernalia, clean syringes. And at the same time, it helps out law enforcement officers because you can have a more frank conversation around, like, do you have a needle on your person? That being said, like, there are a lot of law enforcement officers I interviewed who said giving clean needles to someone who injects drugs is enabling. Like, they may not be on board completely, but then there's also ways to bring them into the conversation and help them to understand this could also potentially be a win for you too. And it's through those sort of points of connection, I think, that you can start to change the conversation. People aren't going to be 100% on board with all aspects of harm reduction tactics like syringe exchange, but if you can find a way in, to include them in the conversation, they may actually be open to it and create an ally, at least for some of these specific measures.
We've used the word stigma, and colloquially, we use stigma to mean taboo. Is there a difference in how stigma is understood by the general population and what it means for research purposes in the context of drug use, public safety?
In our research, we are looking at stigma not as one sort of overarching concept, but understanding that there's different sort of constructs within stigma. In the instance of a person who uses drugs, they may experience stigma because of their substance use. But if they're also experiencing homelessness or involvement in the criminal justice system, this can create these additional layers of stigma that can impact their overall health and well-being. So while everyone can experience stigma because of substance use, these stigma experiences will look different depending on the individual and their other identities and characteristics. And then stigma not only shapes behaviors, but it can also lead to really negative outcomes, both for those kind of holding the stigma and those also who are experiencing stigma. For instance, working as a social worker, I had individuals who had more stigmatizing views towards dually diagnosed clients, so those clients with mental health as well as substance use. I could really note that their approach, the language they used when talking about certain clients, their willingness to really engage and to interact with that individual. And then if we're thinking about within the criminal legal system, some individuals may resist carrying Narcan. And then if we look at emergency rooms, healthcare professionals might express really negative remarks or treat someone who has overdosed differently than other patients. It influences the actions not only of those sort of perpetuating stigma, but also the individuals being stigmatized. It could cause individuals to hesitate in seeking assistance and can have impacts on their health outcomes. People who experience stigma are more likely to have reluctance to seek out treatment or delayed treatment. They have worse psychological well-being. They experience harassment, violence, and bullying. And this leads to increased feelings of shame and self-doubt. It can ultimately lead to a poor quality of life and disability, increased socioeconomic burden. Just understanding the complexities of stigma is really important. And when we're thinking about our responses to stigma, we may need to focus on different domains. For instance, in our research, finding the blame domain seems to be leading stigma. How might we work to kind of maybe focus on that domain in our sort of interventions and work with law enforcement?
I was watching something about housing first, right? Housing first is an intervention strategy for someone experiencing homelessness or someone who's unhoused, in first addressing that before addressing anything else. But a lot of the policies for housing first there's always the caveat of you can't be a drug user or you can't have a criminal record, and how that undermines the effectiveness of something like housing first. And I never really considered that as like the stigma impacting policy making. It has definitely changed the way that I think about policies, who they're intended to benefit and who they're excluding.
The experiences of stigma can also look different depending on where a person lives. In a recent interview with an unhoused person here in Columbus, they discussed how their experiences of stigma impacts their day-to-day life. And again, they didn't use those terms, but they talked about how they're treated by others in the community. And they anticipate being treated a certain way when they're in the community. And they even go as far as to avoid walking in certain areas because they know that they may be targeted, or they told me if you're walking in this area with a backpack, you're going to be stopped. So that causes them to kind of really change just simple day-to-day things that they do. Or they talked about not being served, so they're not welcome to go into a certain fast food establishment. These sorts of behaviors and practices. So it really causes individuals to change how they perceive themselves and with their sort of role or fit within the community.
We talked a little bit earlier about race and drug type. Do you think that police differentiate between drug user and drug type? And then how would that differentiation then impact their behaviors and decision making as law enforcement?
I haven't seen in my research, at least, that there's one drug that is more often bias inducing. I mean, I definitely will say the one thing that law enforcement sort of tends to be kind of firm on is they can be more sympathetic towards people who use drugs, especially with some of these narratives about the overprescribing and the kind of whitened narratives around the opioid crisis. But they are very reluctant to sympathize for people who sell drugs. Even if the people who sell drugs may also be using drugs, there's this idea of like, our job as police is to get these drug pushers off the street. And in my position as a researcher, I have more curiosity towards, what drove someone to sell drugs. Are they also using drugs? Understand a little bit more about their reality and not just assume that they're sort of an evil person because they're selling drugs. But I think law enforcement, that's a way tougher one for them to get behind. But in terms of the opioid crisis, the kind of whitening of narratives around people who use drugs may have produced greater sympathy or empathy among law enforcement.
Can you say more about what you mean, the whitening of the narrative?
There is a narrative that's come out through a lot of popular culture, books, media, that the current opioid situation, the opioid epidemic or opioid crisis, is something that created a whole kind of new class of victims among disenfranchised working class whites in the United States. And I think, we could potentially attribute to this slightly more harm reductionist shift in policy in the United States. It's because it was sadly, for some reason, easier for policymakers and legislators to gain sympathy for people who were addicted to drugs if those people were sort of portrayed as white people who were duped into drug use by malicious and irresponsible doctors and pharmaceutical companies.
We've seen, I think, over the years, a shift in officers' roles, this sort of change from the criminalization that we've seen towards substance use to more of a public health approach. I think for some, it's been a little bit difficult because of why they got into law enforcement in the first place. So some said, I watched Cops growing up, or I wanted to catch the bad guys. So they need that sort of bad guy still in the narrative. So the dealers are really, I think, emerging within this as more of a focus. And I think that can be really detrimental because dealers can be a component of risk reduction. Just they're providing the safe supply. So individuals in the interviews that I did talked about sort of risk reduction strategies. And one of them was, making sure to buy from the same person every time because they know what the supply is going to look like. If they use the same amount from that person, they kind of know what the effects will be. But this focus on dealers and drug-induced homicide laws, we were cited as one of the top states for drug-induced homicide charges. If we're looking back at the policy side of things, how can we better shape our policies to support more of these risk reduction strategies or techniques that individuals are using?
Can you quickly touch on what drug-induced homicide means in Ohio?
So if the overdose turns into a fatality, then it can be shifted towards more of a homicide. They try to find out who provided the substance to the person that led to the overdose. And then they can then seek to charge that individual with that death.
It's a really tough one because I think a lot of times for families who lose a loved one to overdose, this is the one way they can feel like some justice is done if you can find the person who sold them the stuff and get them sent to jail. And law enforcement feels like, hey, we got this, drug dealer off the street. But whoever's getting sent to jail is just a cog in a much bigger machine. That's not the root of the problem. We've talked about kind of Good Samaritan laws and why people are afraid to call. Let's say Tasha and I are using opioids together and I've got some fentanyl and I give some to Tasha and she overdoses and I call 911, but she ends up passing away anyway. Immunity protections do not protect me if they find out that I've given Tasha these drugs that caused her death. Again, what is my role in this? Did I want to kill my friend? No. Did I give her the drugs that maybe caused her death? That's possible. So it's very, very complicated and it's a really, really slippery slope. While I understand wanting to do drug seizures and get large amounts of highly fatal drugs off the street, I don't know that this is really getting to the root of the problem, and it may actually end up doing more harm than good.
Narcan or naloxone, from what I understand, is rather polarizing in that the nasal spray has recently been approved as an over-the-counter opioid overdose treatment, and it's extremely effective for saving lives. But some hold the belief that this miracle overdose reverser is just enabling drug use. There's also research that showed how education and use of naloxone by law enforcement resulted in law enforcement having more negative attitudes towards people who use drugs and who may overdose. Seems like a catch-22 where you need law enforcement to have proper training to adequately respond to these types of calls, but that training seems to be backfiring in certain circumstances.
You do hear sometimes, Tasha and I have heard these stories about these ideas that certain people have, not just law enforcement, I mean, people in the general public have this too, that, people who use drugs will have these Narcan parties, or they'll be extra reckless with their drug use because you have Narcan to revive you. Anyone I've ever interviewed in the hundreds of interviews I've done who regularly uses opioids will say the last thing that they want to do is have to be revived with Narcan. If you are opioid dependent and you are Narcan, you are sent immediately to a state of precipitated withdrawal, which is extremely painful, uncomfortable, miserable feeling. I wouldn't expect anyone in the general public to understand this, but I think depending on the kind of organizational culture and what the sort of norms are from command or from up high about the role of Narcan, if it is put out there as a tool in your toolbox that can save lives, and it is what it is, regardless of how you feel about whether or not it enables, then it can be accepted and become a powerful technology. But I don't think that's true across the board. Again, there's plenty of police jurisdictions within Ohio that don't have their officers carry Narcan. So, and Tasha, you've picked up on some other stuff from some of the other law enforcement.
We may have to think of other ways to address stigma that isn't necessarily a stigma training. One way is through focusing on individuals' capacity for change. So having officers identify instances where they have interacted with individuals and they have made a significant change in their life. So being able to use those personal experiences that officers have had. Along with that, how do we facilitate positive interactions between officers and people who use drugs? I think that can really help officers. And we also need to focus, as Sydney was mentioning, so not just on that individual level, but on the organizational level. So what does it look like within the organization? How do the upper level individuals in that organization, how are they talking about these sorts of issues? And within law enforcement, such a hierarchical organization, the upper, supervisors, the senior leadership, I think the officers really internalize a lot of that messaging. So for instance, in some interactions or interviews with law enforcement, they've talked about having senior leadership frame the use and carrying Narcan, not necessarily for a response for overdose, but intervene in case an officer experiences an overdose. So we need to look at how is this being communicated on the organizational side of things, as well as facilitating ways to provide support for officers. In our interviews with law enforcement, there can be a fatalism, and that's related to the, no matter what we do, nothing's going to change. And this can be especially increased when they're responding to maybe the same person, the same house within multiple times within, a week or even within the same day. I think finding ways that the organization can provide support for officers when there may be a bad batch going around, for instance, and there's been an increase in calls for overdose. How can we provide outreach to officers to make sure that they're not getting burned out, that this sort of compassion fatigue isn't happening to these officers?
Do you think that effectively combating the overdose crisis requires police involvement?
They should be brought in the conversation because we have 50 years of a war on drugs. Like, you can't just shut them away and pretend that they haven't been involved. Like, they have ownership over some of this too. I think there's ways in which law enforcement can slowly be brought out of this, but also in a way that they can be on board with, because again, they have other things to do. Law enforcement shouldn't be spending their whole day responding to overdose calls, because really overdose can be handled by people who are medically trained professionals. So if we sanctioned safer use sites, if we sanction drug checking services, there's ways in which we can kind of eliminate law enforcement, and it's like a win-win-win. I think they don't need to be nearly as involved as they are, but I don't know that it's fair to also put the blame on them, right? Like there's other stuff that we can do on a policy level, like harm reductionist policy, decrim policy, that can slowly try to decouple this kind of health crisis of overdose with this prohibitionist war on drugs, punitive criminal justice approach to addiction, which has been like a kind of failure of policy for the past half century.
Sydney summed it up really well. Law enforcement will have to continue to be involved. Some locations within Ohio, they just don't have the same response. So here in the larger cities, sometimes, fire or EMS can show up before law enforcement, but in some of the more rural locations, law enforcement will continue to be a part of this. As Sydney mentioned, if we can think of some of these more structural harm reduction approaches that we can reduce overdose experiences in general. And I think better supporting those sorts of policies, we can not only support people who use drugs, but also the systems as well that the individuals may be interacting with.
Drugs on the Docket is a production of the Moritz College of Law Drug Enforcement and Policy Center. This episode is produced by me, Hannah Miller, and Holly Griffin. Doug Berman is our editorial advisor. The music is composed by Joe DeWitt.